Well,
A warm welcome and very good evening to all dear participants. Resource person of today's session, Dr. Padam Singh sir, and chairperson of today's session, Dr. Seema Dwivedi ma'am.
सीमा जी नमस्कार.
Namaskar.
Now I would like to introduce today's chairperson, Dr. Seema Dwivedi ma'am. Ma'am is currently serving as a professor in the Department of Obstetrics and Gynecology at GSM Medical College, Kanpur. She is also holding the position as National Coordinator of the scheme Mahasi Charak Research and Development Scheme, under which this program is currently running, and National Coordinator of Pandit Madan Mohan Malviya Bal Saksham Yojana of Center of Health Education and Wellness. Ma'am is also Joint Secretary of QOGS and in charge of high risk pregnancy specialty clinic and ultrasound. Ma'am is also Arogya Nodal of GSM Medical College, Kanpur. Ma'am has directly supervised more than 40 thesis works as guide and co-guide and published more than 50 papers in various national and international journals. Earlier, Ma'am was working as an associate professor at Drama Medical College since 2002. He had a special training post in IYC Lab TOT and CEMOC. Ma'am has been also awarded by the Doctors' Day felicitation with Lifetime Achievement Award by KOGS on 1st July 2022. Uh, Now I would like to invite ma'am to currently lead today's session. Please, ma'am. Welcome.
Thank you, Amit. Thank you so much. It is my honor and proud privilege to introduce a great personality, Dr. Padam Singh, who is former Additional Director General ICMR. He has held many important positions in Government of India and has been a member of National Statistical Commission. He has been Additional Director General ICMR from 1997 to 2004 and Director Institute of Medical Statistics 1987 to 97, has worked as Joint Advisor Planning Commission 1979 to 87 and Professor of Statistics at Pusa Institute 1975 to 79. He has been awarded Sankheki Bhushan Award and is the Fellow of Medical Statistics, and this is the highest honor for a statistician. He has been awarded Dr. Sukhantme Lifetime Achievement Award from Ministry of Statistics and Program Implementation, Government of India, and Pandit Ramkrishna Pandey Lifetime Achievement Award from Institute of Applied Statistics. So, sir is going to cover a very important topic of sample selection today, and I now invite sir for his lecture. And we are very fortunate to have him as a speaker. I hope you will all really benefit from today's lecture. Welcome, sir.
Thank you, Dr. Seema Dwivedi ji, Amit. It's a honor for me also. It's not a lecture; it is sharing the experiences. Okay, I will start away. I will be, you know, moving my own presentation from this end. Here we go. Okay, is my presentation visible?
Yes, sir. Visible, sir.
Okay. Now, yesterday, now I covered some of the basic sampling schemes and which are used in surveys. And if you recollect, the first one I discussed was simple random sampling, where each unit of the population is given equal chance of selection at every draw. And thereafter, I discussed systematic sampling. In systematic sampling, only the first unit is selected random and rest are selected, at regular spacing with some predetermined interval. And I explained with the examples. I was asked to explain the difference between linear systematic sampling and circular systematic sampling. Change किया तो वो कहेंगे. I also covered cluster sampling and other sampling schemes. Now, I have added, some examples of linear and all that. Just a minute. I think it is the yesterday's thing which is shared. I'll be sharing what I updated today. Take a moment. Where? Yes, करके देखो.
उससे नहीं होगा. कौन सी टॉपिक थी?
आगे 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 चलो. और आगे और आगे और आगे और आगे और आगे चलो 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 चलो. या इसके आगे होगा ना. ये है नहीं इसमें. तो वही क्या.
आप कंटिन्यू करो तब तक मैं दोबारा इसमें.
Okay, so this is what I discussed, the basics, the circular systematic sampling, cluster sampling, and multi-stage sampling. These were the basic sampling schemes which I covered yesterday. Now, when I was presenting the stratified sampling, I was asked to give examples of stratified sampling. And the common example is, supposing we are interested in estimation of, say, anemia levels among women. Now, women is a group, and within women we could have subcategories which are called strata, and these are what we call is, one could be pregnant woman, the other could be lactating woman, the other married woman, and unmarried women as well. So anemia levels will be different for all these four subcategories, and this is what we call as strata. So we divide the population, into these subgroups, and these subgroups are considered as strata, and we collect sample for each of these. The other example, which is for HIV estimation, prevalence of HIV among the population. Now, when we talk of HIV estimation among the population, the strata could be high risk. High risk means sex workers. Then moderate risk. Moderate risk will be those who are attending STD clinics, and the rest will be general population. So, because the prevalence of HIV will be different in the high risk moderate group and the low risk group, now we have to do independent sampling in each of these. So this is what it is. So this is what we discussed yesterday. Now the advantage of stratification are that stratification ensures adequate representation of various subgroups or subdivisions of the population. And these subdivisions themselves may be of interest. The other one is, stratification may be desired for administrative convenience. Administrative, yesterday I gave the example that, the desert may pose a different problem of, travel and other things. The tribal may be the other thing and the general thing, So these are administrative zones. These are administrative regions in a state. So when we are talking of administrative regions which are strata, so the field officers or survey work can be established, in various conveniently administrative zones with well-defined jurisdictions, and thereby leading to better organization and supervision, capabilities. And this is what I said, surveys in tribal, desert and hilly and other remote areas may pose problems and need different approaches of sampling. And hence it would be advantageous to create separate strata for each of sub areas. Now, the issue in stratified sampling is how to allocate the sample. Should we be taking, equal number or unequal number? If it is unequal, then what way? Now, there are four ways of allocating the sample. Supposing let me take the example of the HIV estimation in the population. And we are talking of HIV estimation in the population. Then if we have to cover a population of, say, a sample of 10,000 persons, now how that 10,000 has to be allocated between high risk, moderate group risk and low risk groups. Now that is the concern. It could be that we take equal number, that is the first one, all equal, that is from these three strata, we take equal sample size. The other could be proportional. Proportional means what is the proportion of high risk group in the population, the moderate risk group in the population and the general population. And on the basis of our own perception, the high risk group constitutes about 2 to 3% of the total population. The moderate risk group constitutes about 10 to 15% of the total population, and rest is general population. Now this is one way, but please note, the HIV prevalence among the general population will be very, very low, and that in the high risk group will be the highest. Now the third one is optimum variance, that is the strata where information is more, the higher samples should be selected from that. So there, see, though the proportion was, 2, 15 and rest, the way the sample selected was that we selected more than 80% of the sample from the high risk group, about 15% of the sample from the moderate risk group, and only 5% from the high risk group. This is depending upon what is the extent of information we expect from these strata. So third is optimal variance and the optimal cost. Cost could also be a criteria. So these are the ways of allocation of sample in the stratified sampling. Now, having selected a sample from different strata, when we try to estimate the parameter of the population, now we have to use appropriate estimation procedure. That is, having obtained the estimates for each of the strata, we have to weigh it. The weights are the stratum proportions. Now this is how this is mathematically represented here. So when proportional allocation is used, then the sample becomes weighted sample. That means the sample mean will be unbiased for the population mean and so on. So this is one of the important considerations in the estimation. Now, another method of sampling, which is used these days by many, is what we call as PPS sampling. Now, the idea behind PPS sampling is the units of the observation may not be of the same size. If village is the unit of selection in most of the community-based surveys, when we are talking of surveys at the district level or the state level, village is the sampling unit. If village is the sampling unit, we know the villages vary in size. And there are villages which have very low population, maybe less than 1,000. There are villages with the population 1,000 to 2,000, 2,000 to 5,000, and there may be villages more than 10,000. Now, all these villages cannot be given equal chance of selection. And what is considered here is, let us give the chance of selection to villages according to their population. So if the probability is in proportion to the size of the village, That type of sampling is what we call as PPS, probability proportional to size sampling. And this probability proportional to size sampling is very commonly used in most of the large scale surveys. And if the character under study is directly proportional to the size, we have the experience of immunization coverage surveys. Now, the higher size villages, they had better coverage levels. And the small size villages, generally are remote, and there, the coverage levels are very low. If that is the situation, then PPS sampling helps us in getting better estimates as compared to equal probability sampling. Now, here also, having selected a sample by PPS, we have to use the appropriate estimation procedure. Here is the value which we have observed in the sample, it has to be weighted inversely with the probability with which it is selected. Now, this is something which one has to remember, and you cannot use PPS and then take sample mean or sample proportion as the estimate of the population. Now, let me give one example how a sample could be selected by PPS. Supposing, let us see this example which I have given here. Suppose a village has 8 sampling units and their sizes are 50, 30, 25, 40, 26, 44, 20 and 35. This is what I have given in the second column. What we do is we cumulate the size. Cumulate means the first value of the third column is 50. The next value in the second column will be 50 plus 30. Okay. The value of the second unit is added to this 50, that becomes 80. Then the value of the next unit is added to this 80, that becomes 105. Then 40 is added to 105 and likewise. This is what is cumulative size. The total cumulative size for all the 8 units is 270. And if I select a random number from 1 to 270, then the probability assigned with the numbers, if the random number happens to be 1 to 50, unit 1 will be selected. Please see the first row, last value. If the random number selected is 1 to 50, unit 1 will be selected. If the random number happens to be 51 to 80, unit 2 will be selected. If random number happens to be between 81 to 105, unit 3 will be selected, and likewise. So this is, it says, so it is in proportional. And here, now, if we have to select 2 random numbers between 1 to 270, supposing the numbers selected are 116 and 47. Now, please see, 116 is between 106 to 145, that is 4th unit. Please see, 116 in the cumulative total is for the 4th unit, and 47, if you see, this corresponds to the 1st unit. And this is how these units are selected in the sample. Then there is a sampling scheme which is a combination of PPS and systematic sampling. And here the difference is, rather than selecting the random numbers individually, we select only a random start and then every kth unit with that interval is selected. Let me explain with the help of this example. In this example, please see, there are 20 villages and the size in hundreds of these villages is given in the second column. The cumulative size is given in the third column, and the range, that is the associated random numbers for each of the units, is given in the last column. Now here, if you see the cumulative total, it is 700. And if I have to select 5 units, then this 700 I divide by 5 and I get the interval, sampling interval. Okay, the sampling interval is 140. Please note 140. How this 140 interval is calculated? This is 700 divided by 5. Now I have to select a random start from 1 to 140. Supposing that random started 101, which is I have indicated here, and this 101, the other number you have to add 140 to this, so it will be 241. Add again 140 to this, it will be 381, and likewise 521 and 661. Now the random numbers associated with these, you can see 101 lies between 93 and 120, which corresponds to unit 3. The number 241 in the range 231 to 288, which are shown in the, the orange color, that corresponds to the unit, the village number 7. That 381 is 370 to 416 in that range, last column I am seeing. That means it corresponds to the unit number 11. And likewise, so it is unit 3, 7, 11, 15 and 20 are selected. This is the sample of 5 units which is selected by PPS systematic sampling. Now, there is a 30 cluster sampling methodology which is used by WHO in all field surveys. Now, let me just explain. This is the method which is used at the district level. This was proposed for immunization coverage surveys, but this is generally used for all other parameters as well. In this, 30 villages are selected using PPF systematic sampling, the method which I explained earlier. By that method, 30 villages are selected. That is step 1. And step 2 is, in each selected village, 7 children are selected. Let me explain how that is selected. Please see the diagram which I am showing here. So what is done is, having reached a village, selected a village, from the center of that village, we draw a rough sketch. And this rough sketch indicates lanes and by-lanes from that, going to all directions of the village. And in this example, if you see, there are 10 lanes. Okay? Lanes, I have numbered 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Now, one of these lanes or sub-lanes is selected randomly. And on the selected lane and sub-lane, I know there are households. I need not count them. What I do is, I walk from center of the village and to the last, in the end, and count my steps. Supposing the steps I have walked are 32. I select a random number from 1 to 32. Say the random number selected is 7. So I walk again from the center and I stop at step 7. And with that, on the left of on my left hand of the house which is there, I try to find out whether there is an index child. Index child here is in the age group 1 to 2 years. And I consecutively cover 7 households with that index child. And that is what is a cluster. That is a cluster of 7 children. Okay? So cluster of 7 children in 30 villages. That's why the name is 30 cluster sampling method. And for the selected household with the index child, the information is collected on the, the parameter of interest, whether the child has received all vaccinations or individual vaccinations and things of that type. And the overall sample size here is 210. And this is how it is done. Now, there is one sampling scheme which is called inverse sampling. You might not have heard this. You know, there are many situations where the event which we are interested in estimating is somewhat rare. And many times it happens is, if we fix the size of the sample, we may not get any unit with that number. What is instead done is, we continue sampling, maybe by simple random sampling or any sampling scheme, till we get some required number of cases with that event. And I am giving the example of leprosy. Now, if you are doing a survey in Delhi, okay, you will not find any case of leprosy. But if you go to the rural areas, there also the leprosy is local and focal. So in that situation, the conventional sampling scheme will not do. What we do is, starting with a village, we continue sampling till we get say 5 to 10 cases of leprosy in that cluster on that sampling, and that's why the name is inverse sampling. Now, I would like to deliberate on type of survey designs. I think this every researcher should be aware of. To start with, there are surveys which are known as cross-sectional surveys or cross-sectional studies, then longitudinal studies, and there are impact assessment surveys. Let me explain these. Now, cross-sectional surveys. Now, these are the surveys where information is collected at one discrete point of time. That means the contact with the respondent with the sampling unit is only once. Okay? Let me repeat again. In cross-sectional survey, the data collection from the sampling unit is only with one contact. And with that contact, on a single variable or multivariable variables, whatever are the variables of interest, the required information is collected. The disease prevalence surveys, or for that matter surveys of any kind, they generally use contact at one point, and that's why these are examples of cross-sectional studies. And this is what it says: prevalence studies involve the analysis of data obtained at single point in time, and these are identifying the presence of disease in a particular study population. Some of the examples of cross-sectional studies are, there were studies done on morbidity surveys, the mortality surveys, the nutritional status surveys, dietary surveys, surveys on NCD risk factors, perception surveys, knowledge, attitude, and practice surveys, and surveys on health-seeking behavior. Yesterday also I mentioned, when I was in ICMR, we did a national-wide study on health-seeking behavior. What percentage of population prefer allopathic treatment, the Ayurvedic treatment, the homeopathic treatment, the Unani treatment, and so on and so forth. And this was asked for each member of the family, and also depending upon the severity of the disease. The findings were that in case of life, style diseases, okay, it is the Ayurveda which is the most preferred one. And when it comes to a child and the bread earner in the family, and the person is seriously sick, then they go to the allopathic system. That type of, these are some of the, leads which we got from that study. Then there are periodic cross-sectional surveys. Now, if the cross-sectional surveys or studies are undertaken in the same specific aspect after a fixed interval, then such surveys are known as periodic cross-sectional surveys. In these periodic cross-sectional surveys, please note the broad sampling design and the object of the study remains broadly the same. And such surveys are done after a fixed interval, but the samples selected every time are independent. So I am repeating again, the objective of the study or the aspect to be covered in the study are same. The sampling design used remains broadly the same, but the samples are collected independently after a fixed interval. Now, such surveys are known as periodic cross-sectional surveys. The examples are National Family Health Surveys. You might be aware, the first National Family Health Survey was done in 92-93, and the last NFHS 5 was done in 2019-20. And these were done at the fixed interval of generally 5 years. And in all these are National Family Health Surveys where sample size covered was over 1 crore households. Initially in the NFHS 1, it was 92 lakhs, but now it is, crossing over a crore households. And this is a very, very planned survey which involves all, principles of sampling. It is stratified, multi-stage, and then using PPS at some stage, systematic sampling at the last stage and things of that type. Then district level household surveys. These were also done. 4 rounds were covered in this. There is an organization known as National Sample Survey Organization. They do quinquennial. Quinquennial means once in 5 years, consumption expenditure surveys. And these surveys are used by the government on estimation of people below poverty line. So poverty estimates are on the basis of that. So these periodic cross-sectional surveys are the important ones, national level surveys, and the findings of these are used in all, planning and policy making. Then longitudinal studies or longitudinal surveys. Now, longitudinal surveys, they employ continuous or repeated measures to follow up group of individuals over long period of times, over years or decades. Longitudinal. That is, following prospectively. These are also known as prospective studies. These are generally observational in nature with quantitative and or qualitative data being collected on any combination of exposure and outcomes. So this is exposure and then we try to collect information on outcome without any external influence. That means there is no intervention. It is just observational in nature. This study type is particularly useful for evaluating the relationship between risk factor and development of disease. So, if we say those who are having some habits, okay, smoker and drinking and things of that type, or those who are otherwise, how the outcomes will be different. Or if we are doing some treatment, okay, then we want to see what is the effect of that treatment on the outcome. Now, longitudinal studies involve the analysis of data collected over time and thus able to identify the changing nature of the disease process. Okay, how the pattern of disease is undergoing change or things of that type. Now, longitudinal study designs, it is just saying, so they most important ones are prospective or cohort. In prospective studies or the longitudinal studies in general, we look forward in time. And in this, the same participants are followed over a period of time. These studies are also intended to determine the natural history of a particular disease process. Cohort studies are special cases of longitudinal or prospective studies in which we follow a group of subjects with common characteristics and collect data prospectively to answer questions related to outcome. Now, there are many studies cited in the literature which are under the category of cohort. But we in ICMR, we did a very big, very important cohort study on the Bhopal gas leak. You might be aware that, in the late 80s or mid 80s, there was a Bhopal gas leak. And we in ICMR, we mounted a cohort study. That is the area which was severely affected, that is surrounding the gas leak plant. Then with a distance and far off, we had three categories of population: severely exposed, moderately exposed, and mildly exposed. Can you believe that we have not only followed those who are, living that time, but also their first and the second generation. That is, children born in those households, those are also being followed. And thereafter, the children, when they got married, we followed them on the birth outcome and any defects in the birth, things of that type. Now, cohort studies are of special interest. So we have, the population or the subjects with the similar characteristics. We followed them on time and try to find out the effect of that exposure. The short-term effect, the long-term effect, the first generation effect, the second generation effect, and so on and so forth. Now, we were also involved in doing the cohort studies on the children who were born small. 2.5 is the normal weight of a child born. But we followed the children, weights were much less than this normal weight, around 1800 to 2 kg, that type. And we wanted to study whether they catch up with the children born with the normal weight or not. That is also a cohort study. Valor and some other centers were the participating centers in this, and we tried to find out, and the findings were, how far they remain behind the normal children. Is there any catching up? With those objectives, these cohort studies are undertaken. Now, this is what we are explaining, the advantage and disadvantage. Advantage is, that these are the only studies which could find out a relationship between exposure and outcome. But the limitations are, it is time consuming, it involves loss of cost, and there is a attrition, loss to follow up. Okay? Now there are longitudinal studies also, there are several sample designs. Please see what is done in the birth death, studies, panel studies by Registrar General of India, we use a fixed panel. It is the fixed panel of villages which are selected, after the interval of every 10 years, and they are followed. So the panel surveys, and here the panel surveys is the population, that point of time. It is only that population which will be followed on multiple occasions. Year 1, year 2, year 3, year 4, year 5, likewise. And the only loss in this will be deaths. That's all. Rest will be followed for all, variables of interest that are collected. The other one is fixed panels plus births. That, okay, in the vital statistic surveys, we have to count the births also. So the second type of longitudinal design could be fixed panel plus births. That means in addition to the population which we have initially recruited, we add births also to that. So that becomes the population they under study. The next one is repeat panels. Repeat panel. That means it involves, different types of panels. Okay, let me just, rotating panel, split panel. Now first let me explain the split panel. Here what it says is, we have a fixed panel, and to that fixed panel we add a cross-sectional sample every year. See, what is happening is that they say, oh, you are only doing this, fixed sample, and what is happening elsewhere you do not know. So we generally supplement this by a cross-sectional sample. So the split sample is a combination of a cross-sectional and a panel survey at every occasion. Whereas rotating is the overall sample is split, and part of it is covered in a year, and its turn comes after, say, 3 years or 4 years. The second split comes the next that year, and likewise. So that means there is a split in the total sample, and then we do that way. There is one scheme that is known as linked cross-sectional surveys. In the linked cross-sectional survey, what is done is, now this is done in the growth of children. What is a cohort of newborn is taken, and they are followed for 15 years. But every time after a follow-up, additional cross-sectional sample is supplemented to that. So that is, after 1 year, we will have the sample of 1 year, which is a follow-up of that cohort supplemented with new children of 1 year. Okay? Things of that type. Similarly, in the second year and third year. The advantage of this linked cross-sectional survey is we are able to calculate the norm. Norm means what should be the ideal weight and height of children of that age group. And also growth. How much is the increment in the height and weight? The velocity is second order. Change in the increment. Now these are the different types of longitudinal samples. This is what I said, the linked cross-sectional sample. Now this is the cohort of newborn followed till 15 years, and measurements are taken on height, weight, etc. The cross-sectional sample of children in different groups selected at each follow-up. That is, after 1 year, the sample of cohort will be supplemented with a cross-sectional sample of 1-year-old children. After 2 years, the cohort will be supplemented by a cross-sectional sample of 2 years, and so on. This way, one would have a sample for the current year supplemented with the cohort, okay, of the past. And this allows estimation of norm, growth, and velocity. Now, there are intervention studies. I need not be going more in details. In intervention studies, there is a control area, there is the experimental area. The baseline information is collected on both, and they have to be comparable. And thereafter, the end line information, one of the area will be intervention, the other one will be the control. And we try to find out the change in the experimental area on the outcome parameters, but that there will be change in the control area as well. So the difference in the change in the experimental area versus control area will give an idea what is the impact of that intervention. So these are intervention studies, impact evaluation studies. Now, non-probability sampling. So far we have discussed, all everything about probability sampling. Now, non-probability sampling, there are only 3 or 4 which are to be discussed. One is what we call as volunteering. Okay, in a study where the participants are not those selected by probability sampling, but these are volunteers. So in this method, a person or sampling unit of volunteers to be included in the study. The examples are, vaccination trials. Okay, you might be aware the COVID vaccination. The COVID vaccination, the study, it is only volunteers who are included. You cannot impose, you cannot force anybody. So there is a call for volunteers, and on the basis of that call, whosoever volunteers to be included that study, it is included. So please note, this is a non-probability sampling. And here, the other thing which I am example giving for testing a newly developed drug, it may not be appropriate or ethical to randomly enlist the patients or the cases. The patients are requested to volunteer. So one was on vaccine trials are on normal individuals. The testing of a new drug is on a patients. Okay, so please remember, these are on the basis of those who volunteer to be included either in the vaccination trial or trial to evaluate the effectiveness or efficacy of a newly developed drug. This is what we call is sampling using volunteers. The other one is convenience sampling. Now this is, there is nothing wrong with the convenience sampling, and this is also used. This method includes those sampling units which are accessible conveniently. Okay, and these are not merely exploratory. Generally, these are exploratory, or these are meant for preliminary research. And this gives just gross areas about the subject. However, it can yield accurate results when the population is homogeneous or well mixed. Okay, so these opinion surveys, election, surveys, the first is the before the election and after the exit surveys, and you might be seeing that these are the surveys where convenience sampling is used, where we try to find the views of the people on a public issue. Television reporters, street interviews without following any probability sampling. So these are also used. And don't say that these are just rejected. The purpose is served using this also. Quota sampling. Now, quota sampling is, if I say crudely, this is stratified sampling with no randomization. That is, number is fixed, quota is fixed. The example which I gave you of HIV estimation, if I say I have to cover 500 sex workers and 200 STD patients and 2,000 general, the woman, the pregnant woman, who will be delivering a child in my study, that number is fixed. That is quota. Okay? But the way I select that number is my choice. Then it becomes quota sampling. So, this is what it says. The procedure allows the inclusion of sampling units in a study for various subgroups. And for example, one may decide to have 100 males and 200 females in a study on chronic kidney disease and select them to serve a specific purpose. These quota are generally decided on the basis of previous experience or perceptions and could also be based on statistical considerations. However, which subjects to be included or left out, this will be, decided by the investigator, and this is on the basis of readily availability, volunteering, and other such considerations. The subjects continue to be recruited till the prefixed quota of the subjects in various subgroups is completed. Now, judgment sampling and area sampling. Now, this method is an extension of convenience sampling and involves selection of the sample based on certain judgments of the researcher. For example, one may decide to draw the entire sample of higher secondary students from one school. Since the preconceptions of the researcher about the representative of one school for all, may be accurate or may have large biases, this method is generally used in pre-testing of questionnaires or focus group discussions. To some extent, the choice of experimental subjects also reflects the researcher's pre-existing beliefs about the population. Now, many times, the researcher decides to study certain peculiarities. And let me give an example. In Rajasthan, there is one Raika community. Let me repeat, Raika community in Jodhpur, around Jodhpur district of Rajasthan. It came out that in this Raika community, there have been no case of diabetes in the last 10 years. Now, this generated a curiosity. What is happening to this Raika community? Let us mount a study on this. So this is, choice of the researcher. I want to study this group of subjects. And a study was mounted. The initial leads were that this population, they drink camel milk. And it could be because of the camel milk that there is no diabetic in that population. And, lots of hypotheses were generated whether camel milk has any insulin property or not. Those type of studies were also undertaken. Anyway, what came out was that it is not the camel milk alone, it is their lifestyle. Humakkad pravritti ke log hain, and it is because of sum total of all these that there were no diabetics. This is what I am giving one example. There could be other examples. There are some villages in, some states, Kerala and all that, and there are large number of twin births. And this is also, area of interest. What is that? Is that this is happening there only, not anywhere else. I remember a case in Bihar. Now, when I visited, there were cases of beetroot spots, one after another. पूरे village में बच्चों में beetroot spots थी. Now, that also creates curiosity for any researcher. तो उसमें वो judgment apply करता है. and that area is selected for research. Now, let me give some more examples of non-probability sampling. In hospital-based research, when we are doing clinical research on patients, then the recruitment of the subjects is just on the basis of inclusion and exclusion criteria. That is, we define set of inclusion criteria on the basis of which the subjects which satisfy this inclusion criteria will be considered for inclusion. Then we examine those against exclusion criteria. That is, those who are having those characteristics which are explained in the exclusion criteria, that will be taken out. And that is the probable sample. Please see, this is not random. And here, the only consideration for including those in the study is their consent. Their consent has to be taken in these type of studies, clinical research. So clinical research, generally what we do is, we recruit consecutive patients. Note, consecutive. Satisfying the inclusion and exclusion criteria, taking their consent till a sample of required size is selected. So this is what is done. You may call it non-probability sampling, but this will satisfy, or all statistical methodology are applicable to such studies. Now the other type of example which I can give you is, in the COVID era, Dr. Sangeeta ji, I was associated with Medanta, the Medicity Hospital, and maximum number of patients were treated at Medanta. There, one study was to be undertaken on Ayurveda as add-on to the standard of care. That is comparing two regimens. One was the standard of care as was being followed at Medanta. The other one was Ayurveda, that is Kada, as add-on to standard of care. Now, we had patients admitted in the hospital. This was to be done on mild and moderate subjects, and we asked for their consent that we will be randomizing, and then you could be either in the usual standard of care or Ayurveda add-on. Everybody opted for Ayurveda add-on. Now this is, all those who are participants here, that Ayurveda was the choice. So what to do with this randomization? What was done was, we recruited those out of those who were volunteering to include Ayurveda as one group, and the rest group was taken as those who are already on treatment with the allopathic. So it is strictly not randomized one. तो randomized में तो it is 1-to-1. एक इसमें लेना पड़ेगा, दूसरा उसमें लेना पड़ेगा. But this is, one group was taken on those who were, to be on standard of care with Kada Ayurveda preparation. They were followed. The other one was, they were on the standard of care, no strict randomization, and they were followed. And the outcome of this study was, the hospitalization study days, उनका जो recovery time था, that was shortened by 2 days. And that is a big thing, by adding Ayurveda to the standard of care, if we can reduce the time of recovery, एक दिन का भी फर्क पड़ता है या 2 दिन का फर्क पड़ता है, that is a big achievement, And we all know that Ayurveda and Kada was so common, those who were not even infected, everybody was taking, that became a, preventive measure as well. The other example, these days, there is a, or before that, let me give you, supposing we have to evaluate the outcome of heart surgery by robotics and the conventional method. You tell me, can we use randomization there? If I am to participate in that study, I will not opt for robotic surgery. Now, the situations where the choice is of the subject, and many times it could be of the clinician as well. Randomization studies per se I am saying cannot be done. But if we have subjects which are matched for all conditions, all parameters, and we have the outcome of robotic surgery versus outcome of the conventional surgery, one could compare. There is nothing wrong with that. The last example I am giving you is, there is a discussion these days comparing Ayurvedic treatment on cardiac patients versus allopathic treatment. Now tell me, if we have group of patients and we have strictly randomized them into Ayurveda treatment, Ayurvedic treatment, allopathy versus Ayurvedic, will participant agree? No. Now it is choice of the participant. One person, I'll only opt for Ayurveda. The other one say, no, I'll only opt for allopathy. There could be, these are the days where we have integrated medicine. That means now the newer, integrated, group will be there where it will be allopathic plus Ayurvedic. Now, is these type of studies, we have to have cafeteria approach. What is cafeteria approach? Those who opt for allopathy, let us recruit with the inclusion and exclusion criteria in the allopathic group. Those who opt for Ayurveda with comparable group with the similar inclusion and exclusion criteria could be included in the Ayurveda group. And third one, who have to be tried on allopathy plus Ayurveda integrated medicine, that will be a separate. These have to be comparative groups. This is what we call a cafeteria approach. तो बहुत सारी situations में, and that's why I am discussing this under non-probability sampling. But this will allow us to compare, okay? Because these are comparable groups which have to ensure कि ये नहीं हो कि भाई जो आयुर्वेदा वाले ले रहे हैं वो बुढ़े हैं, सारे elderly हैं, और जो allopathy wale hai, they are middle aged. No, then study will not be valid. We have to have comparable groups of the similar age, similar gender, similar disease conditions, and things of that type. Now, this is what I thought of covering today. I think my time was 1 hour. I think this is over, and I request the chairperson, okay, for, questions, answers of this session. It is open to question answers.
Thank you, sir. Thank you very much for very informative and knowledgeable session. Now, I would like to request today's chairperson, Dr. Seema Dwivedi ma'am, to please share her views and conclude today's session. Please, ma'am. Welcome.
Thank you, Amit. Thank you, sir, for such a vast and exhaustive lecture covering all the possible aspects of sampling. I heard so many sampling names which I had never heard before. And it was really very interesting lecture with your sharing of experiences and giving examples which are very much needed. I hope the Ayurveda faculty has really gotten some direction for their sampling also. So it was a very, very important lecture. Thank you so much, sir. And now the session is open for the question answers.
Please coordinate.
Yes, sir.
I again request to all participants, then please raise your hand or write your query in the chat box. If there is any query regarding today's session, then please raise your hand or write your query in the chat box.
After every lecture,
Yes,
I
sir.
find questions are not asked. And, I feel that maybe the message has not gone, or maybe everybody has understood it. I don't know. The truth lies in between. It cannot be that nothing has been understood, or it cannot be that everything is understood by everybody. तो भाई सवाल कल तो पूछा था, yesterday they asked examples of stratification, circular systematic versus linear systematic. They asked
Yes.
those questions.
Dr. Shruti, please unmute yourself and ask your query.
Namaste, sir.
Namaste.
Sir, I just want to ask you that convenience sampling and purposive sampling are same or different?
Convenience sampling is one of the purposive samplings. Okay? तो कन्वीनियंट मतलब पर्पजिव में मैंने इतने सारे बताइए ना आपको. कोटा सैम्पलिंग है, ओके, वॉलंटियरिंग सैम्पलिंग है, ओके, कन्वीनियंट सैम्पलिंग, दीज आर ऑल अंडर पर्पजिव सैम्पलिंग, नॉन प्रोबेबिलिटी सैम्पलिंग. ओके, पर्पजिव को बोलते हैं नॉन प्रोबेबिलिटी. पर्पज तो सर्व है ना, एंड एवरी पर्पजिव सैम्पलिंग पर्पज हैज टू बी सर्व्ड. द ओनली थिंग इज दैट वी आर नॉट strictly using that term so-called randomization, probability. But they also serve purpose. So purposive should not be taken with negative connotation.
Dr. Kranti, please ask your query.
Sir, good evening, sir. Padam Singh.
Very good evening.
It was a very thought-provoking and very informative presentation, sir. I have one basic question, sir. Difference between cluster sampling and area sampling.
Cluster sampling. Okay. See, area sampling means you are deciding the area which is required to be studied. एक area हमने ले लिया study के purpose के लिए. Okay? The
Okay.
example I gave was that those who are drinking camel milk, Raika community
Yes,
in that village. Okay?
Yes, sir.
Or the villages where there are more of, without sport cases. वो area sampling हो गई. I have used my judgment कि मुझे यहीं करना है ये काम. Okay?
Yes,
Whereas cluster sampling is a random sampling. Okay? Where I gave the example, in a selected village, on a lane, you select a random start. And with that random start, you take 7 or 5 consecutive households. That becomes a cluster. So cluster is a random way of selecting that group of individuals. Okay?
Yes,
But
sir. Yes, sir.
information is to be collected about all. The other example I gave you was yesterday, the household as a cluster. And this was on health seeking behavior. तो उसमें जो है, आई वांट टू नो कि भाई बच्चों के लिए विच इज द प्रेफर्ड मोड ऑफ ट्रीटमेंट, एल्डरली के लिए कौन सा है, महिलाओं के लिए कौन सा है, और मेल के लिए कौन सा है. सो देयर household serve as a good example of cluster. Okay, so household is sampling unit because it has different members in the household, so that's why a cluster. But information is required to be collected for all individuals in the household. Okay.
Thank you, sir. Thank you.
Very good question. Okay, I appreciate both the questions which have been asked.
Dr. Asay, you need to ask anything? Dr. Asay Nandeswar?
Hello, sir.
Yes, hello.
It was very informative and knowledgeable session.
Hmm.
We have learned a lot about sampling
Hmm.
and sample size.
No,
So,
sample size तो मैंने cover नहीं किया भाई. I think if I am asked, अमित,
no, in
सीमा
between,
जी,
it,
सीमा
in
जी
between,
मेरा एक lecture करा देना sample size पे भी.
Yes, sir. Yes, sir.
It will be
Definitely.
very,
sir.
very useful to all the
in
participants.
between, one formulation was displayed there.
और formula वो estimation का था. That
Right.
was having selected a sample, how to estimate the parameter. Okay.
Right. So, in a multiple way, we have learned the sampling method. Thanks for it. So, my question has been already asked by previous doctor,
Okay.
and I got the answer for it.
Okay.
Thanks
Okay.
a lot.
Good. Good.
Yeah.
I'm happy that you are appreciative of this presentation. Okay. You know, sampling is a subject when we teach, it is not covered in 1 or 2 lectures. We have to spend months in covering all with examples. Anyway,
Yeah.
this is just, we are trying to give you a feel कि भाई
No, it was a
कौन कौन से मेथड्स
very,
हैं, कौन से हैं,
it
कहाँ
was
यूज
very
करने
elaborate.
चाहिए. ओके. And when you use it, please get in touch with me. I'll be able to help you.
Sure, sir, sure.
Dr.
Thanks a
Salini,
lot.
please unmute yourself and ask your query. Dr. Salini.
Yes, please.
Dr. Dharmen Kumar Pandey, please unmute yourself and ask your query. Dr. Dharmen Kumar Pandey.
हेलो
Yes.
जी नमस्कार सर.
नमस्कार नमस्कार.
सर मैं ये जो 2 दिन का आपका ये लेक्चर हुआ है सर, मैं
हाँ
इसको थोड़ा प्रैक्टिकली देखना चाहता हूँ कि कैसे यूज कर सकते हैं.
हाँ.
जैसे मैं सर अभी एक वृद्ध लोगों की जो चिकित्सा की एक जो है व्यवस्था बनाई गई है यहाँ छत्तीसगढ़ में, तो मैं ये देखना चाहता हूँ सर कि जो भी वृद्ध लोग हमारे चिकित्सा में आ रहे हैं सर, तो मैं उनके ऊपर एक स्टडी करना चाहता हूँ कि एक जो नॉर्मल केयर हम प्रदान कर सकते हैं और ऐसे वृद्ध लोग जो हमारे केयर से अलग हैं, तो हमारे केयर प्रदान करने से, हमारे चिकित्सा देने से उनको क्या फायदा मिल सकता है.
आई थिंक वेरी गुड वेरी गुड. देखिए, एक तो ये है जो ऑलरेडी आ रहे हैं.
जी सर.
एक तो उन पर एक स्टडी हो सकती है, देयर सेटिस्फैक्शन लेवल
जी
एंड
सर.
व्हाई दे आर कमिंग, इज इट नॉट.
जी
एक
सर.
तो वो उनको कैसे अवेयरनेस हुई इसके बारे में.
जी
Okay.
सर.
And with what expectation they have come and what is their satisfaction level. This is one group. Other group is कितने हैं
जी
जो
सर.
नहीं आ रहे हैं. Is it
जी
not?
सर.
So you have
जी
to
सर.
cover, you have to have a sampling design where you cover both. Those
जी
who
सर.
are attending to the clinic, those who are not attending to the clinic. Those who
जी
are
सर.
not attending to the clinic, the focus has to be on their awareness. Are they aware of this facility? तो
जी
पहला
सर.
तो आएगा अवेयर है. अवेयर
जी
में
सर.
भी दोस्त होंगे जो अवेयर नहीं है. तो 3 ग्रुप हो
जी
गए
सर.
इसमें. नॉट अवेयर, अवेयर बट नॉट यूजिंग, थर्ड इज अवेयर एंड यूजिंग. एंड देन कंपेयर देयर कैरेक्टरिस्टिक्स, रीजंस, इज इट नॉट. एंड लेट मी टेल यू, दिस इज ए गुड स्टडी फॉर, दिस विल बी ए stratified random sampling. Okay, you have to divide
जी
the
सर.
population into these 3 groups. Not aware, तो उसके लिए अलग आपको स्ट्रेटेजी होनी चाहिए, हाउ टू मेक देम अवेयर. दूसरा अवेयर बट नॉट यूजिंग, एंड थर्ड वन इज अवेयर एंड यूजिंग. हियर इट कुड बी ए कोटा सैम्पलिंग, ओके,
जी
और इट
जी
कुड
सर.
बी ए प्रोबेबिलिटी बेस्ड स्ट्रैटिफाइड सैम्पलिंग.
जी सर. सर मैं एक चीज और पूछना चाहूँगा.
हाँ हाँ.
सर मेरे अस्पताल के एक वृद्धाश्रम है,
हाँ
और वृद्धाश्रम में जितने भी वृद्ध लोग गए हैं,
हाँ
तो मैंने सबके ऊपर एक माइन्यूट ऑब्जर्वेशन करना शुरू कर दिया है कि
हाँ हाँ
वो लोग वृद्धाश्रम में रहते हुए कौन कौन सी मुख्य बीमारी से पीड़ित होते हैं और उनकी चिकित्सा का क्या प्रभाव पड़ता है, क्या प्रभाव नहीं पड़ता है। इसमें सर जैसे दो तरीका आप बताए सर, मैं बहुत समझने की कोशिश कर रहा था। एक प्रोबेबिलिटी सैम्पलिंग मेथड, एक नॉन प्रोबेबिलिटी सैम्पलिंग मेथड। तो ये सर दोनों में से कौन सा प्रयुक्त होगा उनके ऊपर?
भाई देख रहे हैं, सारे वृद्ध आश्रम वालों को कवर कर रहे हैं आप, इज इट नॉट?
नहीं सर, सिर्फ सिर्फ एक एक का भी देख रहा हूँ सर।
हाँ, एक का भी देख रहे हो, दैट मीन्स यूर यूनिवर्स इज ऑलरेडी
जी
डिफाइंड.
सर।
You are only covering those who
जी
are
सर।
in the वृद्ध आश्रम. ओके,
जी सर।
पॉपुलेशन डिफाइंड है, कितने हैं उसमें टोटल?
उसमें सर संख्या सर घटते बढ़ते रहती है, पर
फिर भी रफली
अप्रोक्सीमेटली सर 20 से 30 के बीच में रहते हैं सर लोग हमेशा।
तो कितने हैं वहां भाई? कुछ परमानेंट होंगे, कुछ बीच बीच में जा, दैट बिकम्स ए अदर स्ट्रैटिफिकेशन, इज इट नॉट? तो व्हाट आई एम सेइंग
जी
इज,
सर।
इसमें आपको इनिशियल सर्वे करना पड़ेगा ऑन नॉट अवेयर, अवेयर एंड यूजिंग द फैसिलिटी. हर एक में से
जी
फिर
सर।
आपको प्रोबेबिलिटी सैंपलिंग यूज करनी पड़ेगी. Okay,
जी सर।
from that list frame
जी
बन
सर।
गया आपका, and then use
जी
the
सर।
sampling, maybe 30 from each. Okay,
जी सर।
or it could be a varying number.
जी सर।
It's a good. That means ये आपका स्पेशल इंटरेस्ट वाला हो गया ना.
जी सर।
So you cannot do this study in general elderly population. You are doing it only those who are in the वृद्ध आश्रम, old
मैं
age
सर
home.
इसके बाद फिर आगे बढ़ाना चाह रहा हूँ कि
हाँ, फिर
अगर
आगे
मैं
बढ़िए.
यहाँ सक्सेसफुल हो
As a
गया
lead, you will
तो
have
फिर देन
lead.
आफ्टर
हाँ, एक एक
आई विल
एक में
ट्राई
किया
टू
पर.
एक्सपेंड
हाँ,
माय
yes,
स्टडी सर।
yes, very good.
ओके, थैंक यू सर।
Vaidya Maithili, please unmute yourself and ask your query.
नंबर शेयर कर देना भाई. Some are asking my number,
Yes,
my
sir. Yes,
email
sir.
ID and my contact number. Please share with everybody.
I will share in the group. I will share sir's mail ID in the group.
आज कितने लोगों ने अटेंड किया है भाई?
Sir, approximate 369 plus
अच्छा.
through live and YouTube both.
Yes.
Vaidya Maithili, please.
Namaste, sir.
नमस्ते.
We discussed about अगर purposive sampling में decide करना है कि if two types of medicines are to be used, जैसे हमने कार्डियक डिसीज में एलोपैथी और आयुर्वेद का देखा कि the sample should be comparable with related to age, the disease condition, etc. मुझे इसके रिगार्डिंग दिस एक क्वेश्चन पूछना था. हम आयुर्वेद में जब हमारे कोई दिनचर्या प्रोसीजर्स है, जैसे नस्य है, अंजन है, पादाभ्यंग है, इसकी एफिकेसी देखते हैं, तो हमें उसके लिए जो कंट्रोल ग्रुप लेना होता है वो कंपेरेबल हम कैसे रखें, क्योंकि अभ्यंग जो प्रोसीजर हम देने वाले हैं उससे कंपेयर होने वाला कोई दूसरा प्रोसीजर हम तो दे नहीं सकते हैं. तो इसके लिए कैन यू प्लीज
नहीं, देखिए, जो ग्रुप की कंपेरेबिलिटी है, इट हैज टू बी बिफोर दिस प्रोसीजर. ओके,
यस
प्रोसीजर इज इंटरवेंशन. एम आई राइट? दिस इज
यस
आयुर्वेदिक इंटरवेंशन.
यस
चिकित्सा
सर,
का पार्ट है, नहीं है?
करेक्ट करेक्ट.
Is it
हाँ
not?
सर,
What I am
यस
taking comparability is at the screening stage.
यस
जब
सर.
आप उनको स्क्रीन करते हो ना,
हाँ
बिफोर
हाँ
स्टार्टिंग, चिकित्सा करने से पहले, तो स्क्रीनिंग में कंपेरेबल करिए. On
हाँ
screening parameters, you have to have parameters in the screening which could
हाँ
be comparable by both the पद्धतिस. जितने भी
करेक्ट.
पद्धति से आप कंपेयर करना चाहते हैं,
हाँ
स्क्रीनिंग पैरामीटर शुड बी सिमिलर एंड बाय द सेम मेथोडोलॉजी.
जी सर, जी सर. पर बाद में जो हम पैरामीटर्स देखने वाले
नहीं,
हैं,
बाद में तो अलग होगा, आपकी पद्धति के अलग होंगे.
हाँ
आउटकम विल बी सेम, इज इट
हाँ
नॉट? अल्टीमेट आउटकम पैरामीटर हैज टू बी सेम, बट चिकित्सा पद्धति हैज टू बी डिफरेंट.
यस
डिफरेंट,
सर,
yes, but
यस
outcome measure, the outcome has to be measured in the same scale. देखिए, screening has to be in the same scale,
हाँ
outcome has to be measured in the same scale. In between जो है, पद्धति अलग अलग हो सकती हैं.
Yes, yes. Okay, okay, sir. Yes. Thank you, sir.
Thank you very much. Thank you very much, sir, for very informative and very knowledgeable session, and make session very interactive through the query round. I hope that all participants get benefited, definitely get benefited from today's session. This is the first session completed by Dr. Padam Singh, starting from statics. Now we again move on lecture by lecture, statics in biostatics, and with our faculties, they will provide you that how to apply statics in the field of Ayurveda. Sir, again, we thanks you for your presence and share your experience with the participants. Thank you very much, sir.
Okay, my pleasure.
Now, from the Joint State Training Center of Rajasthan, we convey our sincere thanks to all participants for their active participation and commitment for today's session. We heartily thanks the guest speaker of the session, Dr. Padam Singh, who kept participants engaged by the way of very informative and interactive session. We also thanks Dr. Seema Dwivedi ma'am for chairing today's session and sharing his experience and view about the session with the participants. Now, this is the end of today's session. We again will be live in the next session at 6 p.m. sharp. Thank you again. Thank you very much. This is the end of the session. Thank you.
Okay, thank you.